On the behalf of Endocrine Society of India Rajasthan affiliate, I feel honored to welcome all delegates and faculty members for taking an interest part in this important academic event. I'm sure that you all will feel enriched with the knowledge after the completion of this event. Once again, I welcome you all in this thyroid nodule session. Now I'm handing over to our chairman, Dr. Prakash Keshwani, to say something regarding this event.
Respected Dr. S.K. Singh, Dr. Hari Kumar, Dr. Rakesh Sai, dear friends and seniors, a very good evening to all of you. On behalf of ESI Rajasthan affiliate, I welcome you all for today's webinar. We all know that because of COVID, conferences, seminar, and CMEs are not possible. To avoid this monotony of life and to keep ourselves updated, this sequence of seminars has been planned, and Dr. Sanjay Saran has put a great energy for this and is trying for his best. Today we have three iconic speakers which are well-known personalities in the field of endocrinology and will be speaking on various aspects of management of thyroid nodule. I hope we all are going to be benefited by their deliberations. Now I request Dr. Ajay Shah, the course director of today's meeting, to proceed further. Dear Ajay Shah.
Thank you, Dr. Prakash sir. A warm good evening to all the delegates, speakers, my colleagues. The COVID pandemic has generated a crisis in the way we live and how we interact with each other, and also the way we interact with our patients. Despite a plethora of all the negative impacts that this pandemic has created, we have tried to capitalize on the positive byproduct of this situation and try to bring to you a series of webinars which has become so integral in our daily lives, particularly as physicians. Rajasthan Endocrine Affiliate Dialogues is a series of webinars which will be conducted by a group of committed, academically oriented endocrinologists in teaching and private healthcare sectors of Rajasthan. The team came together to optimize and improve the care of patients, those who harbor endocrine problems across the continuum of patient experiences from their diagnosis through long-term management. To that end, READ, or Rajasthan Endocrine Affiliate Dialogue, intends to build a collaborative patient care approach that has incorporated all its members. This session on thyroid nodule is a testimonial to that commitment. This webinar is live and will be conducted as invited guest lectures followed by panel discussions. I would be happy if the delegates put in their questions, and rather than being boring or monotonous, just another webinar, I would be happy if this webinar turns out to be a useful dialogue which is designed to bring us together in pursuit of optimal care of thyroid nodules. For a physician, rather than a didactic lecture, the best way to learn is through a case-based approach. And nobody does this better than Dr. S.K. Singh. Dr. S.K. Singh is a former professor and head of the Department of Endocrinology at BHU Varanasi. And I don't think he needs any further introduction to this panel and to the delegate in general. One of the foremost things that I would like to highlight, not just that he has held almost every position in the academics or in the society, be it secretary, vice president, or president. Very satisfying thing amongst his achievements, which many of us would be proud, are that amongst many of his prodigies, some of them would be delivering lectures, Dr. Rakesh is already in this seminar, and some of them are already the members in the READ team itself. So without wasting time, I will invite, it's my pleasure to invite Dr. S.K. Singh to give a case-based approach on thyroid nodule. Dr. S.K. Singh. Before his presentation commences, I would request all the delegates and panelists to turn their video off and unmute themselves so that the clarity of the session is more better highlighted. Thanks for cooperation of all. Dr. S.K. Singh.
Thank you, Ajay. Thank you for kind introduction. And I'm really privileged and overwhelmed by the invitation from READ, Rajasthan Endocrinology Affiliate Dialogue. They have given me this opportunity to discuss with you all. And as very rightly said by Ajay, that I have a prodigy of my own students all across in this country, and I'm really proud of my students. In fact, I don't deserve to be of great thing, but I deserve to be at least congratulated for the kind of students we had from our center who are serving this nation in endocrinology. So without doing much ado, I think I should proceed with the case-based approach of thyroid nodule. And in next 25 minutes of the presentation, I would bring you 4 interesting cases and how they are approached, and then that would be followed by the deliberations by Dr. Hari Kumar and Dr. Rakesh, who would further dilate the approach to case of thyroid nodule. Thyroid nodule is visible, palpable, incidental, a discrete radiological lesion in thyroid parenchyma. Definitions could be any, but this appears to be very appropriate to describe a thyroid nodule. It could be visible, complained by the patients. It could be palpable by the patient himself, or incidentally detected, but then this is a very discrete lesion of thyroid parenchyma, and that is radiologically identified. Usually the causes are benign, but the malignant contributes to about 5 to 6% of all the thyroid nodule. And this is the major concern, that they should be identified. Otherwise, that could lead to a fatal outcome. So benign, or most of them are benign, but malignant, of course, is very, very important. Amongst the benign, colloid cyst or simple cyst or subacute thyroiditis with nodule, infection, lymphoma, follicular adenoma, Hurthal cell adenoma, or ectopic thyroid sometimes. But malignant, as we know, that could be papillary, follicular, medullary, non-thyroidal, metastasizing to thyroid from the breast or from the renal cell carcinoma. This is one paper I came across, published in MVP Journal of Medical Science from Kanpur. They have FNS cases of thyroid adenoma, thyroid nodule, and majority of them, 48%, were actually benign, but a small chunk contributed to thyroid carcinoma, and that has become a major concern. This is Indian data, but this is almost reflecting the global data also. So starting with the case 1, 45-year male presented with swelling in neck for 6 months. Swelling was noticed by his wife because it was not creating any problem to him, and with little discomfort on swallowing, which might be ignored by this patient. No change in color of his skin, no systemic symptoms, and no significant history of past illness. He was BD smoker 10 to 15 for last 6 years. On examination, general physical examination was not relevant. No feature of hyper or hypothyroidism clinically. And in the examination neck, there was 12 to 10 millimeter nodule in right lobe of thyroid, which was non-tender, mobile, and skin was free. No thrill or no increased vascularity. CBC essentially was normal. Thyroid function again was in the normal range. Anti-TPO antibody was negative, and serum calcium was also measured 9 milligram per DL phosphorus was in normal range and alkaline phosphatase was also normal. So you see that this patient had a thyroid nodule, and without having any biochemical, without having any symptoms other than the little discomfort, and appears to be a non-functioning nodule. So it is not clinically evident to show any clinical symptoms other than pressure symptoms or little discomfort. But if you look at the nodule in general, as a qualified doctor, or try to understand the significance of nodule, one should suspect of malignancy and a high suspicion if it is rapidly enlarging, painless mass, firm or hard lesion, and fixation to underlying structure, vocal cord palsy, or palpable lymphadenopathy, or there is a family history of multiple endocrine neoplasia. But moderately susceptible should be age between 20 to 60, a male, gender, and solitary nodule, which is present. These three factors are there in this case. Previous head or neck irradiation, compression, Hashimoto's thyroiditis in the past, these were not there. But because of these three, at least one would always suspect that this could be a case of thyroid malignancy, and therefore there is a need to further investigate in keeping this in mind. So ultrasound neck was done, and the ultrasound showed hypoechoic solid nodule with smooth margins without microcalcification and extrathyroidal extension. It was wider than taller shape and measured about 1.5 to 12 millimeter. So on ultrasound, the size was slightly more. On examination, it was less. But then when ultrasound was done, the size was 1.5 into 12 millimeter. So one should not take decision based on the clinical examination that this is the size of the gland. And it is very critical also. If the size is large, the chances of having malignancy would be high. So therefore, there has to be a test like ultrasound, and that will give the detail of the information. Now, this is also very important to analyze the sonographic finding. So sonography characteristic and fine needle aspiration cutoff for CA thyroid. In this case, it was intermediate suspicion, as there was a hypoechoic solid nodule with a smooth margin without microcalcification, ET, or the shape was that it was wider than the tall, and the risk of malignancy is around 10 to 20%, and the size was more than 1 centimeter. Therefore, there was a need to FNase this nodule. This is the American College of Radiology TI-RADS scoring, and we should remember that the composition, echogenicity, shape, margin, and echogenic foci. Based on this, I think Hari Kumar will detail it, but then in this case, the score was 4, and therefore it was FNased. The FNAC finding was suspicious for papillary thyroid carcinoma of follicular variant. This is one of the variant of papillary thyroid carcinoma, which is not that malignant, but still this is considered to be malignant. And Bethesda system of reporting thyroid cytology or cytopathology is very important, and we have to remember. So in this case, if it is Bethesda 5, which is suspicious for papillary thyroid carcinoma of follicular variant, then it means that is likely to be cancerous. And therefore, in such case, the surgeon has to take decision to do lobectomy or removal of the gland. Now, the new thing has happened, and I'm sure Dr. Rakesh will be discussing all these, the role of molecular diagnosis in such cases, as to do a lobectomy or the total gland removal. Now, this is based on the molecular diagnosis, normal follicular epithelial cells or suspected malignancy. You have the varieties of mutations that are studied, which could be a fusion molecule abnormality, or it is a molecular changes or mutation, and that speaks of whether it is malignancy and needs to be totally removed or lobectomy has to be done. Now, this has been further refined and improved by doing the gene sequencing. So gene sequencing has come up a new tool to decide and to help the surgeon to take care of the whole of thyroid nodule. So in this case, you see that this is how our understanding about the thyroid nodule has progressed, and we can take a very good decision whether the gland has to be removed completely or partially, or it has to be left in situ and to be followed up for change in the size. Now coming to another case, case 2, a 6-year boy presented with midline neck swelling for 4 years. Mother noticed a small neck swelling which was non-painful and non-progressive. No pressure symptoms, change in voice, no other systemic symptom, no significant past illness, no thyroid disease in the family. On examination, everything was normal except that there is a swelling 25 into 15 millimeter, mobile side to side, non-tender above the thyroid cartilage. Moving with tongue protrusion also. Now one would look at this and think of that this could be a thyroglossal cyst. Now, if it is thyroglossal cyst, it has to be cystic. And if it is solid, then what this is. And therefore, how to progress, what we did. In this case, the hormone profile obviously would be done, and that is showing absolutely normal. Thyroid function was normal. Hemoglobin and CBC was normal. Then thyroid scan was done in this case, and technetium 99M scan showed that there is an increased uptake by this nodule. The alternatively, one would also do ultrasound in this case, and ultrasound would show a solid mass. Since we felt that this is a solid mass and not fluctuating, we decided to go for a scan without wasting time and wanted to see if the gland is taking up or it is cold. In this case, since the gland is taking up and you see that there is no thyroid tissue in the thyroid bed, it means it is an ectopic thyroid gland and nothing has to be done. Even FNSC would not be required because it is ectopic thyroid gland, and ectopic thyroid gland management is different. So this is how the ectopic thyroid gland in this child was diagnosed. Coming to a third variety of case, 32-year female presented with a small nodule in the neck for 6 months. She noticed the swelling after her second baby delivered, I think 6 months ago. She had heaviness in the neck and recalls mild pain in the beginning. She had palpitation and feeling warm for last 2 months. No symptom of hyper or hypothyroid other than feeling of warmth and occasional palpitation. No past history of any illness during pregnancy or in earlier pregnancy. In general examination, she had pulse rate of 100 per minute regular. No sign of toxicity other than this. Nodule in the right lobe of thyroid measured 12 into 8 millimeter and non-tender mobile. So usually we go for this list of investigation. CBC, ESR is to be done for knowing that it is inflammatory condition or infectious disease. Thyroid function test should be done. TSH has to be done. Anti-TPO antibody. So we did all these 4 tests in the beginning, and the finding was that CBC didn't favor any infection. ESR was also not raised, not in favor of subacute thyroiditis. Thyroid function suggested there is a thyrotoxicosis. TSH was suppressed 0.05. Anti-TPO antibody was positive, 1200 unit, and anti-thyroglobulin antibody was not done, which is also just to add to condition of autoimmune thyroid disease. So ultrasound was done in this case. And as I said, that radionuclide scan was not done, and perhaps knowing the condition, it is not required also. So thyroid ultrasound showed hypoechoic area, very small hypoechoic area with very low vascularity and some cystic changes, small tiny cystic area with peak systolic volume of in thyroid artery was 28 ml per second. So it is not a very vascular tissue on the ultrasound. And it was FNS'd because there was a nodular appearance. And once there is a nodule of size more than 1 centimeter, better to go for FNAC. FNAC was done, and that suggested lymphocytes are dispersed as isolated cells with Hurthal cells, abundant granular cytoplasm, and prominent nuclei. So the collection of the Hurthal cells, that gave the appearance of a small nodule, and that was seen as hypoechoic on ultrasound, but FNAC suggested diagnosis of Hashimoto's thyroiditis. This is a fourth case. A 50-year female had non-productive cough for uh, 2 months, and a CT chest was done because that patient presented to a physician who thought of having some pathology in the pulmonary uh, chest, and the CT was done, which showed a 12 millimeter thyroid nodule. And she didn't have any feature of hypo or hyper or pressure symptoms. Systemic evaluation was normal. So we would say that this was a thyroid incidentoloma, incidentally detected, which was unrelated to the problems the patient was suffering from, and therefore CT picked up a thyroid nodule. Thyroid function was normal, and anti-TPO was negative because it was further investigated. Ultrasound showed 15 to 8 millimeter hypoechoic nodule in the right thyroid lobe with central vascularity, but no microcalcification, and several 3 to 5 millimeter nodule were noted in both the lobes. FNAC of dominant lesion was done, and Bethesda, it was flush, that is a follicular lesion of undetermined significance, which was repeated after ultrasound at 3 months, which showed slight increase in the size of the nodule. Repeat FNAC again was similar to what was reported at the first stage. Now, okay. So assess this case, actually, I would say that this was a little peculiar incidentoloma, and the histology was flush. We need to confirm, because that might be a point of worry. So we need to confirm whether this is a case of malignancy or not. Now, in this case, a gene expression classifier would be of help. The patient had a right hemithyroidectomy, and the thyroid tissue was studied histopathologically. 12 millimeter follicular adenoma composed of mixed micro and macro follicular tissue, and there was an area of 5 millimeter intrathyroidal micropapillary thyroid cancer. So a small tiny lesion which was showing intrathyroidal micropapillary thyroid cancer. Now you see that this is a little different from what we have seen. Now in this case, there is a dominant follicle which is almost appearing benign, and this could be confirmed only after lobectomy done in this case. So 6 weeks after surgery, the TSH was maintained, and micropapillary thyroid cancer was identified in this case. And right now the status of micropapillary thyroid cancer, that usually they are non-progressive, and since lobectomy has been done, there would be only a need to follow it up for further progression to thyroid malignancy. Now here comes the role of molecular study, which I'm sure that Dr. Rakesh will cover up the significance of molecular study in such cases. Now this is not available almost at every place, but we hope that this is going to be made available in most of the places. And now in our own country, there are some centers, they are doing it. There are some agencies, they are helping us to get this kind of study done. And we have not ordered the test, except BRAF mutation. One of our patients had undergone this study. But gene expression classifier, which is quite new thing, will help in such cases to assure your patients that nodule is benign or is malignant, and it is of some aggressive treatment is required. These are some of the methods for from the FNA tissue that can help to know whether it is malignant or benign by immunocytochemistry, galectin-3 or other immunocytochemistry, and then a gene expression classifier, which is 6167 gene expression classifier, to rule in or rule out possibility of thyroid malignancy in adenoma. I think I close it here by just telling you the final diagnosis of the cases. Cases 1, follicular variant of PTC, total thyroidectomy and histopathology, BRAF positive and thyroxine replacement, and follow with thyroglobulin and anti-thyroglobulin antibody 6 monthly. Serum calcium phosphorus had to be done in patients who have undergone total thyroidectomy. Case 2, it was ectopic and was put on thyroxine suppressive dose that will suppress the size, as well as that will also ensure that patient doesn't develop hypothyroidism, which is likely to be there in any case of ectopic thyroid tissue. So follow up by thyroid ultrasound only for any change in the size, because ectopic tissue can also undergo a malignant transformation. Case 3, Hashimoto's thyroiditis with toxicity and simply beta blocker and reassurance, and follow up with T3, T4, TSH, as they have risk of getting converted into hypothyroidism. Case 4, micro and macrofollicular adenoma with micropapillary thyroid carcinoma, only hemithyroidectomy, TSH has to be maintained in low normal range, and follow with triglyceride, serum thyroglobulin and anti-thyroglobulin antibody monthly. So take home, thyroid nodules are common entity that a surgeon must evaluate and take the help of endocrinologist. Nodules are found through the physical examination or incidentally through imaging modalities performed for other regions. Ultrasound is the primary study by which thyroid gland is imaged. Nodules 1 centimeter or larger or sonographically suspicious sub-centimeter nodules warrant cytological analysis through fine needle aspiration to determine the risk of malignancy, and molecular biomarkers have shown great promise in their ability. So I think with this I close, and I expect this will be further dilated and further highlighted by next 2 speakers. Thank you very much.
Thank you, Dr. S.K. Singh, for giving such an illustrious overview of thyroid nodule. And I see that there are no questions to your presentation in the chat box, but I would like you to request to stay till the end of the lectures of our next 2 speakers, just in case anyone joins in late and has a question for you, so that he may be benefited. Once again, thank you, Dr. S.K. Singh, sir. So radiology, as highlighted by Dr. S.K. Singh, plays a central role in the diagnosis and management of any medical condition in general. And let's see how imaging plays the pivotal role in the management of thyroid nodule by Dr. KVS Harikumar. Dr. Harikumar is a consultant endocrinologist at Hyderabad. He has been awarded with various prestigious orations and medals to his name. His ResearchGate score is very decent, and his H index is also more than 15. He's got numerous awards, and let's, without wasting time, invite Dr. Harikumar to his presentation on radiology of thyroid nodule. Dr. Harikumar.
Thank you, sir, for kind introduction. Thanks to Team Rajasthan Royals, led by Professor Prakash sir and ably batted by Sanjay, for inviting me here. It's a pleasure to be part of all of you with the panelists, and it's an honor to speak with Professor S.K. Singh and Professor Rakesh, who was one of my examiner and one of my teacher. So thanks to everybody for inviting me here. And Professor S.K. sir has already laid the benchmark very well about the clinical presentation. So I shall take you further about the imaging and how do we conduct the imaging, what are the things to look for, and how do we take the patient forward in the approach. Few decades back, the goiter was the actual major problem. I mean, courtesy to iodization of the salt and seminal work by Professor Kochupillai and others. Now we don't see much of those goiters, which was there from time immemorial. Now we are mostly grappled with the nodule which is coming up rather than the goiter which is coming up. So I will cover the topic under the following headings: the imaging techniques, and thyroids I will just spend some time because that is the crux of the imaging, and few practical tips. You have seen this mostly from Professor SK's talk. 36-year-old female just noticed a nodule. Somebody underwent a PET scan for some other disease, and then the PET showed some uptake in the thyroid nodule. Cervical spondylosis, somebody gets an MRI, there is an incidental reporting of nodule. So there are different ways and means of the patient reaches you with a nodule, and the moment somebody detects this thyroid nodule, they will obviously refer to an endocrinologist for further opinion and how to proceed further. This is where the matter lies. And the first and the most important thing is to rule out the malignancy. That is what we are all going to do whenever there is a growth in the body. So that is what the imaging is likely to help, and possibly will give a clue when to do FNAC based on the imaging characteristics. And it is most important to remember that ultrasound decides the further management course in about 2/3 of patients. So that is where the importance lies. A good ultrasound will put you in the right path, and a bad ultrasound will take you away from the right path and leads to disastrous consequences. So that is where it's important to identify that ultrasound, the role of ultrasound in the thyroid nodule. What the topic was imaging of thyroid nodule. So, for the benefit of some residents, there can be some therapeutic role of imaging also. So I've just classified it as diagnostic and therapeutic. The therapeutic one, I will just spend one slide because there are various ultrasound guided procedures available to address the nodule, be it laser ablation, ethanol injection, high frequency microwaves, high intensity focus ultrasound, basically to kill the nodule with the energy. So that is ultrasound guided therapeutic role. Predominant one, what I'm going to spend time is on the diagnostic module, that is ultrasonography. Some recent advances as far as the elastography is concerned, which is an extension to the ultrasound. CT, MR, PET and radionuclide, I am going to just touch upon, not commonly done for a nodule. And coming to the basic principles of thyroid nodule ultrasound, patient should be supine, neck fully extended, and standard frequency commonly 7.5 Hz frequency probe is used. You can use 10 or 15 depending on availability. The transverse plane and sagittal plane both needs to be approached, and you look at the isthmus and you look at both the lobes, and you look at commonly the lateral part of the neck for any lymph nodes. Mind you, for any thyroid ultrasound, when a nodule comes, always look for lymph nodes. If it is not done, please refer back to the radiologist to get the information about the lymph nodes. The summation of it will give you either a qualitative and quantitative risk estimates for thyroid cancer. How we do it, the qualitative and quantitative, I'll explain to you in future. This is a conventional transverse scan of thyroid. This is the isthmus, this is the left lobe, this is the right lobe. These are the strap muscles of the neck. This is the esophagus beneath the left lobe, and this is the carotid artery. Important thing I have shown you is this here is, when you look at the echogenicity of the nodule, you compare it with the thyroid parenchyma. Let us presume this is a trachea, obviously. Here, if there is a nodule, you compare it with the parenchymal echo texture, and you compare it with the echo texture of the strap muscles of the neck. So that is where your classification occurs. So whenever you look at ultrasound of thyroid nodule, what are the features you look at? First is the composition. That is it solid? Predominantly solid means at least more than 50% of the nodule should have solid. Predominantly cystic means more than 50%, or is it purely cystic? The higher the solid content, the higher the risk of malignancy is. So this is one aspect you look at in the nodule. Second is echogenicity. I'll show you the images also subsequently. Is it marked hypoechogenicity, mild hypoechogenicity? Is it isoechoic to thyroid, or is it hyperecho? The hyper and iso have less risk of malignancy, whereas marked hypo or mild hypo have a higher risk of malignancy. Shape, Professor SK has shown in one of his cases, the tall than wide has increased risk of malignancy, and this is one of the important feature because the growth planes, if the nodule grows cutting across the planes of the tissue, that shows that it has a malignant potential. So that is why a oval or a horizontal nodule, you don't bother much, whereas a taller nodule than wide, you consider that it is more chances of malignancy. Calcifications, you have microcalcification or a macrocalcification or peripheral rim calcification. More amount of calcifications, microcalcification indicates that there is increased risk of malignancy. The margins, obviously, like any other swelling or a nodule, ill-defined margins, then obviously the risk is more, or it may be speculated, or the margins are ill-defined and because of extension outside the thyroid capsule. And the last one is the vascularity. Vascularity has got mixed reviews in the literature, so that is why it is not well considered. But a marked intranodular vascularity considers or increases the risk of malignant potential to an underlying nodule. So these are the features which you will look in any ultrasound report of thyroid nodule. Some of the endocrine centers are doing an ultrasound by themselves. We all have been trained partially in it. So it is like, it's important to look at the nodule yourself to determine what risk category it belongs to and whether you can subject them for FNAC or not. So these are some of the representative images you can see. This is a nodule, you can see it's a oval nodule. This is the thyroid parenchyma, and this is a nodule. So it is almost like same as the thyroid parenchyma, so it is isoechoic. Compare these two here. The nodule is hypoechoic in comparison to the thyroid parenchyma. So this is hypoechoic. And look at here in the last one. This is almost looking like a cystic nodule, but this is not a cyst. You can see it's a solid one. This is markedly hypoechoic nodule. The echo is even less in comparison to the strap muscles. So this is where this almost borders like a cyst, but it is not a cyst. So this is how the echogenicity of a nodule varies. This is the cyst, almost looks like a black because it's a fluid filled one, and in any ultrasound it appears black. This is a cyst, and this is a spongiform nodule. This is predominantly cystic because more than 50% is occupied. The spongiform is like a multiple small cysts which occupy more than 50% of the nodule. The spongiform is actually considered as a benign one. So you don't require to do FNAC. And some of these nodules where you do FNAC, the predominantly cystic ones, post FNAC, the size of the nodule goes down, and because of the drainage of the fluid, and patient may feel that it has therapeutic role also, but it is just a misnomer. This is a nodule, what I have said about the oval one. Here it is wider than taller. And you see the other image. Here it is taller than wide. If the ratio is more than 1 in the transverse plane, this has higher risk of malignancy than when compared with this. So that's important to identify what are the characteristics of a nodule, what direction it is growing, what are the contents. See the margins, they're ill-defined. Whereas here, if you see, they're right, well-defined, possibly encroaching into extra thyroidal space. So these are the important things to identify in an ultrasound report. This is a peripheral rim-shaped calcification in a nodule, whereas here there is mixed calcifications. There is almost to the extrathyroidal tissue also. So this is a calcification which spectral and mixed calcification also gives you an increased risk of malignancy. TIRAD score was proposed almost 2 decades back, but given some important criteria by American College of Radiology, the ACR TIRADS is commonly called. It takes into consideration the 5 important features as what I have shown: the composition, echogenicity, shape, margin, and the echogenic foci. You give points to each one of them what is visible. See here, the taller than wide straight away gets 3 points. Okay, and a total points will give you what is the total TIRAD score of a particular nodule. And based on the amount of points, you subject them for FNAC or further course of action. Obviously, the next is FNAC only. Unfortunately, the ultrasound alone will not give you bypass the step of FNAC and straight away take you to surgery. But the risk prediction model, almost if you have more than 7 points in TIRADS, it almost points to 90% chance of detecting a malignancy. So, but you need to confirm the tissue diagnosis before you subject a definitive surgery. So it is important. So 0 to 2 points, you may not do a FNAC and then just follow up. Whereas 3 and above, you generally do a FNAC based on the TIRAD score. Some further follow-up or further refined versions of TIRADS is elastography. In the clinical practice, in the surgery clinics in MBBS days, a harder the nodule, the risk of malignancy is more. That's what has been taught to all of us during, Bailey's teaching. That is, hard nodule means increased risk of malignancy. The same thing is employed by the elastography. It only sends waves, either, the 2 techniques, what you do, either you manually apply the strain with the ultrasound probe, or the shear wave technology where you send the radio waves and try and compress the nodule and see how hard or how soft it is. The more firm nodule, the higher the malignancy risk. It's because an extension of a non-invasive mode, it has gained a lot of traction in the recent decade, and possibly it helps in more negative predictive value that when not to do a FNAC. Possibly that will be the catch. That will be the clue for doing a elastography. Like with any other ultrasound techniques, there are a lot of individual subjective variations for all these all these techniques. Important, another caveat here is the follicular CA and medullary thyroid, they're usually soft. So even there may be a nodule, it may be a soft nodule on the elastography, but they may be harboring a follicular CA. So that's important to know the false negatives and false positives of any technique. So to look at the image, this is a ultrasound image where you can see a ill-defined hypoechoic nodule here. And the same one on a elastography, you see the blue indicates hard and whereas the red indicates soft. The darker the blue, the harder the tissue is. So here it is, it's almost like very hard. So it is an indicator that you should go for FNAC because of the further characteristics of the nodule. Other imaging modalities not commonly used as far as the nodule is concerned, but yes, they are considered if you look for a retrosternal extension, maybe a nodule which is not clearly delineated by the ultrasound by virtue of a bone obscuring it or in a ectopic thyroid. So these are the important things, other imaging modalities which you can look at. Some important points to remember. A microcalcification detected on ultrasound indicates a higher risk of malignancy, which is not the case with a CT scan, because CT obviously because of higher resolution picks up more microcalcification, so it does not correlate with the malignancy risk. Another important thing about the imaging is a thyroid nodule detected on PET scan the malignancy rates in the thyroid are almost close to 30%. Whereas in a normal ultrasound-based detected nodule, the malignancy risk does not cross 5 to 10%. So it is only a maybe 4, 5, 10% at the max, the risk of malignancy. But if a nodule is picked up in PET scan, you should be aggressive in identifying what is there inside because the risk of malignancy is more in it. Imaging of nodule is in a different spectrum. This thyroid scintigraphy is only used if you have a nodule and a TSH is suppressed. Please don't do this if the TSH is normal or TSH is elevated. This is only indicated when there is a TSH is suppressed and it may pick up a hot nodule. A cold or warm nodules for some other reasons may pick up. The chances of malignancy of the cold nodule are more. So you should subject a patient to FNAC if you have a cold nodule. For hot nodule, obviously not. This is the techniques for therapeutic imaging of the nodule. All ultrasound guided by and large. You inject the ethanol, you input the laser probe there, or you put a high intensity ultrasound, all those things just to ablate the nodule inside, because there is no medical management of the nodule. So this is what has been tried by multiple authors. I have emphasized this earlier. Whenever a nodule is detected, please look at the lymph nodes, cervical lymph nodes, the paratracheal, pretracheal, which are there beneath the thyroid, because in the thyroid bed, and the cervical nodes. Important features to identify. The lymph nodes are also classified almost the same as a nodule. Are they hyperechoic, hypoechoic? What is the vascularity? What is the shape? What are the calcifications? So the lymph nodes are also determined and described in the same way as what you describe for a thyroid nodule. Few important differences between pediatric patients and adult patients. Professor SK sir showed one of the child, 6-year-old boy with a thyroid nodule. Important thing, the malignancy rate is increased with increasing nodule size in pediatrics, which is not the case with adults. Conventionally, we think that a bigger nodule, the more risk of malignancy, but studies have not shown the same in the adults, which is not the case with pediatrics. So in pediatric, if you have a bigger size nodule, you should be aggressive in your approach because it's important to identify or rule out a malignancy in them. Vascularity may not be of a useful characteristics in pediatrics, which is where the vascularity, intranodular vascularity, has an incremental value in adults. The background appearance, again, abnormality increases the risk of malignancy in pediatrics, which is not the case with adults. And the diffuse sclerosing variant PTC with abundant microcalcification is more common in children and it is less common in adults. So some of the nodules may have different characteristics in adults and pediatric age group, which we all should know in interpreting as per the age of the patient. Two universally important characteristics which you should know are internal calcification predicts malignancy and cystic appearance suggests benign, irrespective of whether they are pediatric age group or adult age group. So that's important to know. So any nodule with pure cystic appearance, you may just leave them, and internal calcification, just go aggressive in your further FNAC and follow up. Some of the advanced versions of imaging, because of the to remove the inter-observer or intra-observer variability, what they have integrated some software in the ultrasound machines itself, wherever you are taking the measurements in a normal conventional ultrasound, the machine captures these images and gives you a computer-aided diagnostic prediction models. These are there, some of the recent versions are there, where ultrasound machines already have got the software in place. So you just finish the ultrasound, the final report is generated along with whatever is the TIRADS score. The operator need not do anything. So there is a systematic review published last year. They demonstrated good performance in diagnosing malignant thyroid nodules, but good news for radiologists is they are not going to be out of job. Experienced radiologists may still have an advantage during real-time diagnosis. Wherever there is doubt, obviously the man makes difference, not the machine alone. Coming to TIRADS, this is the number of different TIRADS which are available in the published literature. The original one was TIRADS alone, ACR TIRADS, Korean TIRADS, Europe started its own TIRADS, and ATA and AS have their own, and BTA has their own classification. Some call it suspicious, some call it low risk, some 1, 1.5, 2. There's too much of confusion and too difficult to remember anything. So how to make sense of all these available different classifications of nodule? This is as far as nodule is concerned. Whenever is nodule, the primary aim is to rule out malignancy, and by and large, all nodules of more than 1 centimeter in size preferably go for FNAC, except in a case of pure cystic version. Rest all you should look for FNAC. Less than 1 centimeter size, if there are suspicious features, if there is positive family history, and if there are other risk factors for malignancy. In nodules less than 1 centimeter, if otherwise looking benign, attempts to identify and treat small cancers will cause more harm than good, because as Professor SK had earlier said, small PTMCs, they don't progress, they don't do any harm. So you need not bother chasing them and then treating them, subjecting them for unnecessary surgery. So clinical approach, obviously first you do TSH. If there is low TSH, that is the only time you do scintigraphy and the nodule either hot or cold depending on the follow-up. Normal or high TSH, you do ultrasonography, and depending on the risk category, you do a FNAC, or if it's a very low risk, you just follow up based on the TIRADS. So practical tips for physicians: do TSH and ultrasound at a good center. Be aware of the TIRAD system. It's important because a nodule of 12 into 12 millimeters present seen in the right lobe of thyroid does not convey anything to anybody, because you cannot do anything further with that report. It is as good as well as a dustbin report. So please ask for TIRADS whenever you are looking at an ultrasound of thyroid. Specifically in the request letter itself, you ask them so that the radiologist honors it. Be confident in advising a simple follow-up. That's also important. When somebody has got a benign looking nodule, somebody may have got with a doubtful in their mind that is it a cancer. Be sure that there is nothing wrong in it. Avoid CT/MR routinely. Please advise Spetacnate only when TSH is suppressed, not in the normal TSH or hypothyroids. And please don't prescribe thyroxine to reduce the size of nodule. It is not going to help. It is rather contraindicated. So to conclude, nodules are very common in general population. Ultrasound imaging is the most important first-line screening tool. Both the man and the machine are important. Nodules detected on PET have higher risk of malignancy. And recent advances like elastography further improved the sensitivity and specificity of it. Minimal role of other imaging like CT and MRI, and minimal role of therapeutic imaging. Reassurance and follow-up is mostly required. And most of the times patients die with thyroid cancer rather than from thyroid cancer. So it's important for us to get convinced that it is not going to kill them. So just be confident in giving the same advice to the patients. Thank you.
Thank you, Dr. Harikumar. It was a pictorial tutorial rather than a webinar itself, by the images and the commentary you made along with it. Already there are few questions coming up based on your presentation, but I would like to take these questions at the end of Dr. Rakesh's talk. So please bear with, and I'm going to ask those questions to you and to Dr. SK, and club those questions with any questions that may be posed for Dr. Rakesh as well. So now I would like to invite Dr. Rakesh Sahai. So it is said that pathology stamps the diagnosis, for any medical disease in general. But if you look at the complexity that the thyroid nodule poses, even the pathology sometimes can make us, think or may think us to do more to the patients than just do a biopsy. So taking all those 2 points, the pathology and the additional tests, some of which were highlighted in the case discussed by Dr. S.K. Singh, I would like to invite Dr. Rakesh Sahai to deliver his talk on pathology and newer molecular and genetic diagnostic tools for a thyroid nodule. But before I do that, let us all congratulate Dr. Rakesh Sahai for being the newly elected president of the Endocrine Society of India. So congratulations, Dr. Rakesh Sahai. On my behalf and from the behalf of READ and all the delegates who may not have known this fact, and I invite you for your talk on pathology and genetic analysis of thyroid nodule. I've already introduced you as a newly elected president of the Endocrine Society, but to make it more formal, you are the senior professor at the Osmania Medical College at Hyderabad. So over to you, Dr. Rakesh.
Yeah, thank you, Dr. Ajay. Thank you for your kind word, but I would like to give a clarification here that the election process is still on. I am not yet elected. I mean, although I would wish to be, but I'm not yet in that this thing. So I would like to just say that I thank the Rajasthan Endocrine Society for inviting me, Dr. Ajay Shah for his kind words of introduction. And I'm indeed honored to be sharing the dais today with Dr. Professor S.K. Singh, my mentor and teacher, Dr. KVS Harikumar, who has been a long associate and a very erudite speaker that we have just heard him speaking about the radiology or the thyroid ultrasonography, which has become a very, very important tool, very important tool, which has to be done in every patient who has a thyroid nodule. And probably the thyroid nodules are also diagnosed with ultrasonography, as Professor S.K. Singh has very clearly shown us. So I thank Professor S.K. Singh for the excellent illustration of the cases that he has done, and Dr. Harikumar for giving us a very good overview of how ultrasonography has become a very important tool in evaluation of thyroid nodules. So I'll go on to the next part, that is discussing about the thyroid FNA, and also what role this emerging role that thyroid molecular markers are playing, because this is becoming a important tool in a subset of these nodules. I would go on to discuss that, particularly the nodules where the clear diagnosis is not available on ultrasonography and on FNAC, where there's a strong suspicion of maybe you're not able to clearly rule out a malignancy. There it is very important to use these markers, although they're not very clearly available, not readily available at every center. But I think in a few years' time, the way things have become, globalization and the advances that are happening everywhere, I'm sure we will be able to have these markers in a few years. Yeah. So I don't have a very great personal experience with the use of these markers because they're not available everywhere as of now. But I'm sure in a few years all of us will be using them more often. So coming to the thyroid nodules, as has been mentioned, that thyroid nodule is a discrete lesion within the thyroid gland that is again radiologically distinct from the surrounding thyroid parenchyma, and they are very common, as was highlighted by Professor S.K. Singh, that they are common to the extent of being seen in 5% of women and 1% of in men. And the most important point that comes to our mind is to exclude a malignancy, and that, as he has highlighted, that it is present in about 5 to 10% of all the nodules, and the rest of them we have to identify those 5 to 10% from the large majority which are benign. And so ultrasonography has become a very, very important tool, as Hari Kumar has highlighted the importance of that. And this is something which has become very important. The assessment of these non-palpable nodules, which are incidentalomas, as Hari Kumar showed, that there could be various scenarios where you are faced with a patient coming with a nodule which is picked up incidentally because he's gone for some other imaging, and these small nodules, then we need to decide whether we need to evaluate them further or not to evaluate them further. So, but generally what we say is that nodules more than 1 centimeter are the ones which we need to go for further evaluation. Less than 1 centimeter, generally we don't go for any evaluation, but there can be situations where there is associated lymphadenopathy, or if there is some suspicious features, very highly suspicious features on those nodules, we may have to actually go for further evaluation, as was illustrated by the case that Professor S.K. Singh has shown, the lady who presented with a nodule which was less than 1 centimeter, and that turned out to be a micropapillary carcinoma. So important points in the history, as was highlighted earlier, these are the important points: the family history of thyroid cancers, the growth, the rapidity of growth, the hoarseness, presence of any features of involvement of the surrounding structures, history of childhood head and neck radiation. These are all important things, and which have to be kept in mind when we are evaluating that. And this has already been highlighted, that we need to look at the shape, size, consistency, presence of cervical lymphadenopathy, the fixity of the nodule to the surrounding tissues, and presence of vocal cord paralysis. So these are all important clinical pointers which have to be looked at when we are evaluating a nodule. And as Dr. Hari Kumar has shown us the approach, and Dr. S.K. Singh has also shown us this, that once the first test that we need to do is to look for the TSH. If it is low, then you go for a scintigraphy. If it is normal, then you go for then I think the next step would be going for a ultrasonography of the thyroid, and then you decide which are the lesions which need to go for FNAC. And as Dr. Hari Kumar has shown us, that there are several different types of thyroid scoring, but important to know that you should identify those important features which would help us in saying that, okay, these are the ones who need to go for further cytological evaluation by FNAC. And then the next step would be, then based on the FNAC, then you decide on some of them who go for surgery, some of them who do not go for, clearly do not require surgery. But there's a group which is all this group is the one which requires further testing, which could be in the form of these molecular tests. And these are the ones which will go for surgery for sure. These are the ones which would not go for surgery, as I will go on to discuss a little about these in the next few slides. So I think Dr. Hari Kumar has highlighted how we need to decide about the sonography, and decide who are the ones who need to go for FNAC, and based on the TIRAD scoring. And so all those who have a size more than 1 centimeter, with features with features like, having a solid nodule with microcalcifications, taller than wide, rim calcification. All these situations are with a size more than 1 centimeter definitely require FNAC. Size more than if they are spongiform or partially cystic, without any sonographic features described above, there could be described as low suspicious lesions. There again, you would do FNAC if they're more than 2 centimeters. If they're purely cystic, then they are the only ones which, without any solid component, they would probably be the ones which do not require any further evaluation. But rest of them would require FNAC. And so FNAC, as we see in a large majority of the nodules, FNAC is the procedure of choice for evaluation of the thyroid nodules. It is most accurate and cost-effective method for evaluating thyroid nodules. Ultrasound guided FNAC may be required in some situations. Many situations, FNAC can be done without even ultrasound guidance. But wherever there is a likelihood of getting a non-diagnostic cytology, where there is, this is particularly when 25 to 50% is cystic. So if there's a cystic and solid component, not completely solid. If it is completely solid, then you could just go with a even without a ultrasound guidance. But if you have got cystic and solid components, there you could probably get non-diagnostic cytology if you don't use ultrasound guidance. So there you require ultrasound guidance. And also when it is difficult to locate when the nodules are not clearly palpable and picked up on ultrasound, then you should use ultrasound guidance for doing the FNAC. And also in posterior located nodules, these are the situations where ultrasound guidance is required. Otherwise, also if you're having ultrasound guidance and if you can do it and pick up from even amongst within the solid nodules, we can pick up from those suspicious areas. Then I think where there is hypoacuity, there's calcification, microcalcification, then I think it is better to use that. But otherwise, in these situations, you definitely require to go for ultrasound guided FNAC. And then again, just like you had the TIRAD system, but you have several different TIRAD system. But here again, in 2007, the Bethesda system for of thyroid cytopathology was evolved, and this has again been improvised, and there were several other rounds of improvisation. And currently we have one which came out in the consensus meeting of 2017. And this thyroid nodule pathology FNA should be reported using this diagnostic system of Bethesda scoring, and it has 6 different categories. The category 1 is non-diagnostic or unsatisfactory. The category 2 is benign. Category 3 is atypia of undetermined significance or a follicular lesion of undetermined significance. Then category 4 is follicular neoplasm, which is suspicious for follicular neoplasm, a category that also encompasses the diagnosis of Hürthle cell neoplasm, and also any of those lesions which are suspicious for Hürthle cell neoplasm. Then you have the suspicions for malignancy, one category of suspicious for malignancy, SUSP, and malignant lesions. So these are the different categories that are identified in the Bethesda system. And here you can see this is the revision of all this in 2017. This system, this was updated further, and you have the 6 categories now. The undiagnostic category, non-diagnostic or unsatisfactory FNA is probably the cancer risk is 5 to 10%. And the one which is categorized as category 2, benign, is a cancer risk of 0 to 3%. And atypia of undetermined significance or the follicular lesion of undetermined significance, the risk is 10 to 30%. And the follicular neoplasms, which are here you have a cancer risk of 25 to 40%, 50 to 75% in the Bethesda stage, category 4, 5, and category 6 is malignant with 97 to 99% risk of malignancy. So this is how you see that these are probably the 3 categories. These 2 are definitely the ones which go for surgery. The problem comes here where you have a 10 to 30% risk of malignancy, and you have to subject all of them to what you can call as a diagnostic surgery to assess whether they have cancer or not. And it is in this category that further testing would be very helpful. So as was shown by Professor S.K. Singh also, these are the 5 different or 6 different categories, as you can see here, of the Bethesda system for reporting thyroid cytopathology. As you can see, this is the follicular lesion of indeterminate significance. And you have the suspicion for Hürthle cell neoplasm, follicular neoplasm, and then you have suspicion for papillary thyroid carcinoma and papillary thyroid carcinoma, as you can see here. So this is the Hashimoto's thyroiditis, where you have tearing of the tissue lymphocytes is seen with scanned follicular cells and colloid. Microfollicular adenoma, again, as you can see here, a densely filled with colloid macrofollicular adenoma nodule. Then you have the Hürthle cell lesion, which is showing sheets of large polygonal Hürthle cells, also called as oncocytes or Aschenzi cells, with abundant oxyphilic cytoplasm. The nodule is benign. There is no evidence of vascular or capsular invasion after surgical excision. Then this is what is typically seen in a papillary thyroid cancer. You see that cells and nuclei are large. The cytoplasm has a ground glass appearance. The nucleoli are prominent, and the nuclei have clefts, grooves, and holes due to intracytoplasmic inclusions. So this is called as orphan Annie sign. Then the Samoma bodies are also very typically seen in papillary thyroid cancer, and then you have the appearance of a sticky colloid with very little colloid on FNAC seen in patients with in those who have a papillary thyroid cancer. So as I mentioned here, that the non-diagnostic cytology is the one where we have a concern with non-diagnostic cytology. You have a significant 5 to 10% risk of malignancy in that category, and since you do not have a proper cytology available, you need to repeat the cytology with ultrasound guidance. And repeated non-diagnostic nodules without a high suspicion sonography pattern can be kept under close observation or undergo surgical excision for histopathological diagnosis. So this has to be correlated with the clinical and the ultrasound features. So if you have ultrasound features which are not suggesting high suspicion, and however the FNA is showing non-diagnostic cytopathology, then you need to sort of keep them under close observation. But on the other hand, if you have high suspicious features on ultrasonography, then you need to actually consider them, take them up for surgery, and so this is how you need to sort of look at these non-diagnostic FNACs. So repeat FNA with ultrasound guidance will generally yield a diagnostic cytology specimen in 60 to 80% of these nodules, particularly when the cystic component is less than 50%. So this is the issue that has to be kept. And when do you repeat? It should be the FNAC, repeat FNAC should be performed no sooner than 3 months after the initial FNA to prevent false positive interpretation due to biopsy-induced reactive or reparative changes that may be induced by the previous biopsy. So recent studies have, however, refuted this earlier observation, where they said that the previous FNA may induce some reactive or reparative changes, and recent studies are saying that you can probably reduce the waiting time and go for a repeat FNA earlier than 3 months also. And if clinical and ultrasonographic features are suspicious for malignancy, we need to shorten the waiting time and have a repeat biopsy done sooner, and probably err towards going for surgery for surgery. Now, looking at those categories which are clearly benign, if the nodule is benign on cytology, further immediate diagnostic studies or treatment are not required. Malignancy rates of only 1 to 2% have been reported in large retrospective series that analyze the utility of systematic repeat FNA in nodules with prior benign cytology results. So, repeating the FNA very soon is not required in these categories of Bethesda 2. And however, in the malignant cytology, when you get a malignant cytology, the cytology result is diagnostic for primary thyroid malignancy, then surgery is generally recommended. An active surveillance management approach can be considered as an alternative to immediate surgery in some situations where you have a patient with very low risk tumor, that is papillary microcarcinoma, without clinically evident metastasis or local invasion, and no convincing cytological evidence of aggressive disease. So this is something which is coming up very recently. This is what is being proposed recently, although most of us would err on the side of going for surgery, but this could also be the choice which is made in patients who are having high surgical risk because of comorbid conditions. If you have an elderly person, as Dr. Harikumar has said, that people are more likely to die with thyroid cancer rather than of thyroid cancer. So therefore, when they have significant comorbidities, it is not worthwhile subjecting them to immediate surgery, because you're not likely to gain anything great by operating such a papillary microcarcinoma. And those who have a relatively short lifespan because of other comorbidities, again, these are situations where you not like to proceed with surgery soon. And this is a situation where you'll follow active surveillance management approach. So following a thyroid surgery for papillary thyroid microcarcinoma, defined as tumor less than 1 centimeter or less in size, disease-specific mortality rates have been reported to be very low, less than 1%. Local regional recurrence rates are also very low, 2 to 6%. And distance metastasis is also very low. So these excellent outcomes are more related to the indolent nature of the disease rather than to the effectiveness of the treatment. And based on these, I think these are situations where a less aggressive approach is being recommended now in the recent guidelines. And we don't have very good, however, we don't have very good features to differentiate them from those which progress, and hence therefore surgical reference resection is done in most of the cases. At least we go ahead and doing surgical resection in most of these cases. So recent data suggests that specific molecular profiles such as the coexistence of BRAF with other oncogenic mutations such as PIK3A or the AKT1 or the TERT promoter or the TP53 mutation may serve as more specific markers of less favorable outcome of PTC, the microfollicular varieties, where if you have these lesions, if you have these mutations, then you may prefer to be more aggressive, and in the others you may prefer not to be so aggressive. So this is again a role for molecular markers being done here. Now, the major role for molecular markers comes in those with the indeterminate cytology lesions, those with all these three categories here. So FNA reliably establishes the diagnosis of benign or malignant nodule in 70 to 80% of cases. FNA puts them into either of these two categories, a benign category or a malignant category. But in the 20 to 30% where you have these categories, that is where you have Bethesda 3, 4, and 5 categories, what we need is that we are at a sort of confusion, because we have a variable rates of malignancy. 6 to 75% of them are malignant on final surgical pathology. So identifying those who are more likely to be malignant is important, and excluding those who are less likely to have malignancy is important in terms of avoiding unnecessary surgeries. So different molecular markers are being used in that category of patients. What are the different markers? You have immunohistochemistry, but that requires a block to be present. And you should have a tissue block to be to do this immunohistochemistry. You can do it for galectin-3, you can do it for CK19 or HBME1. So these are ones which have not gained so much popularity because you require a tissue block there. However, the ones which are gaining popularity are checking for the mutations and gene rearrangements. Either you look for the BRAF, RAS mutations, RET PTC mutations, or the various mutations that are used. And then we have got gene expression and microarray analysis also, which can be done. Different systems have been developed. So basically what we can say is that we have three categories of molecular markers. The first one is identification of particular molecular markers of malignancies, such as the BRAF mutation or the RAS mutation. The second category of tests is looking for the high density genomic data for molecular classification. So this is the genomic sequence classifier, GSC. And then you have another this thing of measuring the FNA trained microRNA. So classifier combined with molecular markers of malignancy. So these are the three different systems that we would use to look for, further evaluating this category of patients who are in that zone of having a follicular lesions of undetermined significance. So if you look at the the ones, you have this thyroid sequencing analyzer, which is again used for picking up these mutations. It picks up the RAS mutations, it picks up the BRAF mutations, and apart from this, it looks at 14 thyroid cancer related gene mutations and 42 types of gene fusions associated with thyroid cancers. So these are all that are tested by this ThyroSequence version 2, and it is considered as a rule-in malignancy test. So it is not for ruling out, but it's more for ruling in a malignancy. And amongst the Bethesda type 3 and 4 nodules, the test is marketed to have a high sensitivity and specificity, positive predictive value, and a negative predictive value, which are all very, very good, suggesting that this is a very good test for ruling in where you have got a high suspicion of malignancy. The other tests, I mean, if you look at the mutation test, I mean, as I mentioned, it's a more of a rule-in test because of the high reported specificity of this and a positive predictive value also, which is 84 to 100%. And so mutation panels have been expanded, as we saw in the previous one or the previous slide, with the ThyroSequence version 2 and version 3 also, as I mentioned, subsequently has also come up and picks up all these mutations and all the gene rearrangements which are known to be associated with thyroid cancers. Then the second category, as I said, is the genomic sequence classifier, mRNA genomic sequence classifier, and this was introduced by Veracyte in 2011, and this is called the FMR GEC system. And this is more useful for ruling out malignancy. So it includes a 142 gene expression molecular assay, and uses microarray technology to measure mRNA expression profiles to determine whether a thyroid nodule is suspicious or benign. So the test's primary aim is to spare patients with cytologically indeterminate FNA samples unnecessary surgery. So this is more for ruling out. And amongst the indeterminate or suspicious nodules, Bethesda type 3 or to 5, the test has both a high sensitivity and high negative predictive value. So this is good for ruling out, in contrast to its low specificity. So it has a low specificity and positive predictive value, but has got a high sensitivity and high negative predictive value. So therefore, it can be used as a good test to rule out malignancy. Then the other category of tests are the microRNA gene expression combined with mutational analysis. And this is a multi-platform test based on expression level of 10 microRNA genes and mutational analysis to detect the presence of 8 oncogenes. So this is available as this system called ThyraMIR or the ThyGeneX. In a study of 109 indeterminate nodules, 54 of which were resected and 35 of which were malignant, the combined test had a negative predictive value of 97% and 91% for the FLUS and AUS category and follicular neoplasm category in the Bethesda. And positive predictive value for malignancy was 68 and 82% respectively with these two systems, the ThyraMIR and the ThyGeneX2. So then you have the MIR TH type microRNA, again a microRNA based classifier, mRNA based classifier test. It again has has a 89% sensitivity and 92% specificity. So it has got a good both good sensitivity and specificity. So what we have seen is that these three molecular marker tests, these three categories of tests which we have seen just now, use different techniques to evaluate indeterminate biopsy samples, and all perform well to identify benign nodules which do not have to proceed to surgery. So with the newer generation techniques, we are getting good results. But if you look back, but however, the performance with Hurthle cell lesions is something which is always a challenge. But the current newer versions of FMR GSC have improved the sensitivity and specificity of Hurthle cell for Hurthle cell lesions also. And so this is one challenging area which is there. And just a word about the immunohistochemistry, as I mentioned that you have different strains available, Galectin 3 or the HBAMI1. All these are good, but it requires the availability of a cell block to perform this staining. So we don't generally have the cell block available in those situations, and so therefore this requires again a biopsy to be done and then a cell block to be used. So that's not very popular nowadays. We go with the initial cytology sample that is taken, and we could take an additional sample at that point of time to be kept for the molecular tests, and they could provide value in terms of going for the molecular tests. So the other point is that molecular testing is not recommended in some situations, like an indeterminate nodule if other indication of surgery is there. So if you have an indeterminate nodule in that category, but indication of surgery is there, right? Like the nodule is very large, or if there are compressive symptoms, or if the patient prefers to go for surgery, then there's no point going for the molecular test. You can straight away go for surgery itself. And a limitation of the current molecular markers is there insufficient data to recommend. I mean, it's not studied well in pediatric patients less than 18 years of age, and therefore it's not routinely used in that category of patients. And these tests, however, still need to be further validated in larger numbers of patients to complement, to provide us very useful information. We still have to look for further data, look for further modifications or improvisations of these techniques to get better information on these on this because what we have seen in the studies as early as 2011, we found that there was in the sense that this was not performing very well. Even nodules with no detected mutations, the malignancy rates were 6, 14 and 28% respectively. So even when you didn't have mutations detected, you still could have malignancy. So therefore, I think there are certain limitations of these tests. We cannot consider them to be picking up every sort of malignancy, but there are improvements. If you look at this study, which is in 2017, what we find is that that we found a systematic review of 8162 patients, of whom 42.5 have benign lesions. Amongst these benign lesions, RAS mutations, RET, PTC rearrangements, and all the other PAX8 and PPR gamma rearrangements were present in a significant number of these benign lesions also. So it sees that it shows that benign lesions can also harbor mutations, but it's, I think, the whole sort of the entire sequence that has to be studied, and it is not just identifying these mutations may not provide the entire answer. So the F-forma genomic sequence classifier has undergone a improvement in 2017. You have the new variant which is launched, and that has shown better performance rates, and it has shown better sort of sensitivity, specificity, and the positive predictive value also, and negative predictive value. So this is becoming, these systems are becoming better and better, and we expect them to sort of provide us more useful information in the years to come. So what we are saying is that finally I would like to, in the conclusion, see how these influence how these markers influence the surgical dissections. When surgery is considered for a patient with solitary, cytologically indeterminate nodule, thyroid lobectomy is a recommended initial surgical approach. So because of the increased risk of malignancy, total thyroidectomy may be preferred in patients with indeterminate nodules that are cytologically suspicious for malignancy, positive for known mutations, specific for carcinoma, or sonographically suspicious or large nodules, or in patients with familial thyroid cancer or radiation exposure. So I think what we need to understand is that the type of surgery that is to be done also is decided based on these markers, based on the sonological appearances, the size of the nodule, and also in other family history of thyroid cancers and history of radiation exposure. These would decide in favor of going for a more extensive surgery, a total thyroidectomy, rather than just going for a lobectomy. So finally, I would conclude by saying that these markers are having an emerging role, and we need to sort of look at their performance, and once they're available to us, I think we could use them more often in this categories of patients where we could avoid unnecessary surgeries. Thank you all for the patient here.
Thank you, Dr. Rakesh. So with this, we come to the end of the invited guest lecture part of the webinar. So all the three speakers stick to their time. They comprehensively covered the topic. The clarity, the newer topics, and the controversies were well highlighted by each of them, which brings me to a certain set of questions that may have arisen, not just in my mind, but in audience's minds as well. So first, my question will be to Dr. S.K. Singh. You know, the approach and the case-based presentation that you had made, was it really applicable to solitary thyroid nodule? Generally, clinicians may be faced with a situation where clinically palpable may be just a single nodule, and you order an ultrasound and you find that there are multiple nodes. So is the approach that has been discussed now, how do you answer to that? And a second question that was asked by Dr. Pankaj, I'm not very sure where he belongs. He asked this question about the usefulness of peak systolic velocity on the Doppler. I think you had answered him in the chat box, but for the sake of a detailed answer, either you or Dr. Harikumar could answer that. And the second question that was posed from the audience comes from Dr. Parikh from Pilani. It looks, at least to him, that the way the approach has been presented looks like that the thyroid nodule is a disease that needs to be treated at a higher tertiary care center with a teamwork and stuff like that. So how are you going to answer these questions? So I'll just repeat. First questions, your approach on clinically solitary nodule, but on ultrasound, you find that there are multiple nodules. What would be the approach? Second, peak systolic velocity in Graves' disease. And lastly, the whole approach of thyroid nodule, is it beyond the purview of a primary care and the patient needs to go to a tertiary care to have the right cure of his disease? So Dr.
Thank you.
SK,
Yeah,
and
thank you.
maybe the answer may be supplemented by Dr. Harikumar because he also answered his question.
Thank you. Yeah, for the answer to the first question, when we see a solitary thyroid nodule, as I discussed, that's a right approach that we order for hormone profile and other tests, and then ultrasound is done. We always request our sonologists to follow at least the thyroid scoring, and based on that we proceed. If it is multinodular and the sonologist has not suspected of malignancy and the gland is not large, we do not proceed further. But if there is any suspicion in any of the nodule, normally when it's multinodular, they have to take FNSE from, they have to do ultrasound, and if there is a suspicion, FNSE should be done from multiple nodules. And in case of any kind of suspicion, that there has to be surgical intervention, and we refer a case to surgeon. So this is our simple approach, that a solitary nodule, sonologist opinion is important. Even then, if we suspect that this could be a malignancy, we do FNSE and we follow the guideline more than 1.5 centimeter with hypoechogenicity and some change in the size, shape. FNSE is done and Bethesda is followed. So based on Bethesda, again, index of suspicion of malignancy is there. We always go for a referral to surgeon, and they do surgery, and histology gives the final answer. We have not gone for molecular study till date in any of the cases. However, I've heard some of the surgeons have also taken help of BR BRAF mutation in deciding whether total thyroidectomy or lobectomy is to be done. PSB, this is very favorite area for my center. We do not have nuclear medicine and we don't trust on nuclear medicine, truly speaking. So we believe that ultrasound should be the stethoscope of thyroidologist in thyroid clinic, and ultrasound, a good ultrasound should be done, and PSV should be measured. If it is more than 40 ml per second, 100% specificity of being vascular thyroid, and that favors Graves' disease. If it is less than that, it could be Hashimoto's thyroiditis with toxic phase. So that is the significance of doing PSB. The third question was, what was the third question again?
Whether the approach to a thyroid nodule is beyond primary care and
it is the way, the way it has been presented. You see, many things are emerging out, and they are in evolutionary stage of managing thyroid. Because a person having a thyroid nodule, if he knows so much that malignancy could be a concern, I don't think that he will sit quiet and he will just ignore it. He will definitely like to take second opinion. Therefore, is wise to investigate with the facilities available to that particular center and then refer it. If you don't have very good sonologists, you refer to another center where good sonologists are there. If you don't have a good cytopathologist, you have to refer it to a center where a good cytopathologist following Bethesda and reporting very rightly. I think, and then you need a good surgeon also to take it out and then to decide whether total or partial or lobectomy has to be done. So there is a step-up approach in management of thyroid nodule, and you need to refer it higher. But then you can investigate at one stage, you do it. You can go for the second if it is available at your place. But then finally, the answer would be from a tertiary care center. That's my take. I think one might like to differ also from this, but then this is.
I would very much agree with what sir is saying, except that maybe in just where it's very clear-cut malignancy, clear-cut, I mean Bethesda 5 or 6. There, I think picked up if that is picked up, then you may not require much of evaluation. But otherwise, I think it is becoming a stepped-up approach where you require more and more tests and better investigations to be certain about what we are dealing with.
So, Dr. Rakesh, Dr. Deependra is the endocrine surgeon of our state. He wants to know how he can ask for or do a requisition for the genetic test that you had mentioned. And I would like the opinion of Dr. Hari Kumar on the same question, the last question. When I thought this webinar should have told the general physician when to refer a thyroid nodule, because once we say that, okay, most thyroid nodules, they are indolent and not so much growing, and they are slow growing cancers. Even if you are delayed, probably not much harm is done, because the statement that you made that perhaps not, you may actually be doing more harm if you are over investigating. So first, Dr. Rakesh, on the availability of the genetic test, and second, Dr. Hari Kumar's view.
Yeah, right now I think because we don't have it in every center, we have certain diagnostic labs which are doing it, doing these genetic tests, particularly doing genetic tests for thyroid cancers and for many other conditions where we could refer them. I have not personally used much of it, and but I think these are only a few of them which are available in our country, which are providing these services. Dr. Hari, may
okay. No. Regarding the nodules and those three questions, actually, The issue is it can very well be tackled at a peripheral center. The step-up approach is there. What I have actually said is the sonologist is the key factor. I mean, conventionally, most of us would have seen a ultrasound pelvis for PCOS. The radiologist reports bilateral PCOS seen. I don't want a bilateral PCOS report from sonologist. I want the number of follicles, the volume, the size, location, what are the characteristics. Then let me interpret how it is. If you just write bilateral PCOS advised hormone correlation, that's what the standard sonology report comes. The same thing in the thyroid. Just by mentioning a nodule does not help me. It requires the characteristics. So it can very well be done at a peripheral center. And if you just put the sonologist, just send a snapshot of how a TIRADS is done. You just interact with him once. It can easily be, communicated, and then that can be followed up very easily. If you are very sure about the sonologist capability and a good benign report, good low risk report, you can just safely follow it up without doing anything. That is first thing. So it can very well be tackled at periphery without any problem. Obviously, if you have higher risk and your cytopathologist is not up to the mark to interpret a thyroid cytology, then possibly you require a higher center and other molecular tests, which I'm sure most of us have not used at all. Second thing, as far as the nodules, which you suspect a single nodule and you have a multinodular on ultrasound, which is the commonest thing to happen actually. ACR TIRADS say you should have the score for at least 4 nodules, which are dominant looking. And look at the most highest scoring, you should look at the FNAC of the highest scoring nodule. You should score individually for 4 nodules and then take FNAC from the highest scoring nodule. But again, that again is a subjective variation. As I showed, there are so many variations to TIRADS that you cannot actually practically follow them. Look at the most malignant appearing nodule and possibly go for it, go for FNAC and then follow it up. As far as Graves, thanks to Professor S.K. Singh, sir, it's actually the, last 15 years, possibly 5 or 6 only nuclear scans have advised for Graves till date. You don't require actually, most of the patients you can actually diagnose using ultrasound. Within 5 minutes, you can get the diagnosis and then start treating comfortably. Of course, there are some issues, gold standard, nobody can touch it. But in our setups, where most of us have the accessibility of ultrasound, mostly within ourselves, within the centers, within departments, it's very easy to do. So that's my take for this.
Thank you, Dr. Harikumar. Thank you for sparing your valuable time and educating not just the Rajasthan Endocrine Affiliate, but the more than 100 delegates that have joined and viewing this webinar. You can continue viewing our webinar because we will be starting with the panel discussion. So for the panel discussion, I'm first inviting Dr. Prem Prakash Patidar, sir, if he can just come up on the screen.
Sir.
Welcome, Dr. Patidar. You can introduce yourself first.
Yeah, I am Dr. Patidar, endocrinologist working in Jaipur in Jeevan Rekha Hospital as an endocrinologist. And many of here like Keswani sir and are my mentor. And I'm thankful to Dr. Shah sir for inviting me as a panelist.
So, Dr. Patidar, I would like to know, based on the discussions, and what is the appropriate follow-up for a thyroid nodule patient that you are practicing and would like to recommend to our colleagues?
Yeah, this is actually very important. Whenever we diagnose a thyroid nodule, the first question from patient side is whether it is malignant, whether surgery is needed or not. If surgery is not needed, then when to come again for follow-up and what is the strategy for follow-up. If we see the various literature and guidelines, one large series published in 2018 in JCM, and that shows that when they followed the children for many years, they found few results, and they concluded that if a nodule is more than 4 centimeter, it was presented in Dr. Rakesh sir's presentation, then if it is more than 4 centimeter, it should be resected surgically immediately. Why so? Because there is a risk of malignancy up to 15 to 16% in future. So we should not keep it as in follow-up. Other thing is we have to decide follow-up by various factors. Like if somebody is having nodule which has various features in clinical and ultrasonic examination, if it is more towards the risky factors like taller than wider, if it is solid single nodule, if you compare with single nodule, solitary nodule with multinodular goiter, the solid nodule has more chances of developing malignancy rather than multinodular. Second thing, cystic, if it is predominantly cystic, as it was presented in Dr. KVS sir's presentation, if it is more than 50% cystic, the chances of malignancy is lesser when we compare with the solid. So if there is a risk factor like cystic, the lesser follow-up is required. And the best follow-up strategy is to do ultrasonographic examination. Ultrasonography once in a year, if it is patient is lesser risk, and if it is higher risk, then FNA to be done immediately depending on the tirade. If it is more than 3, 4, or 5, then we have to do FNA. And in adult, as far as adult is concerned, if 2 FNA are benign, showing benign cells, follicular cells or benign lesions, then we should do ultrasonography even once in 2 or 3 years. So follow-up depends on the risk factors. If we compare the multinodular goiter with solid nodule, the risk factor is more in solid compared to the multinodular goiter. And one more thing is, what is multinodular? Multinodular is a patient is having one nodule and second nodule more than 5 millimeter in size. So that is multinodular goiter. So the speed or growth rate is more in multinodular, but the risk of malignancy is lesser in multinodular goiter. Other significant thing is various types of other risk factor, like if size is growth rate is if in follow-up it is growing more than 50%, the risk of malignancy is much higher than the slowly growing nodules. So if growth rate is very high, we have to be cautious and we should follow up repeatedly. But for general guideline, we can say we should follow most of the patients with risk factor yearly by the ultrasonography, and if required, if tirade is more than 3, 4, 5, then we can go for FNA, repeat FNA.
Thank you, Dr. Prem Prakash. That was very comprehensive. Thanks for coming. And now I would like to invite Dr. Ravindra Shukla on panel.
Okay. Hi, everyone. I'm Dr.
Ravindra Shukla. You can introduce yourself.
Yeah, okay. Thank you. I'm Associate Professor in Department of Endocrinology, AIIMS, Jodhpur. And I'm very grateful to Ajay Bose for inviting me as a panelist here.
So, Dr. Ravindra, I would like to ask you, based on what we have seen, I like to ask you what has been missed. So, we all know that during the pandemic that we are witnessing, thankfully we are past the peak right now. But I just wanted to know at All India Institute at Jodhpur, pertaining to thyroid nodules, did you defer the cases? Because this is one area of endocrinology where everyone would like to defer these cases because, so what was the modus operandi during the peak of the COVID? And second, I would like to highlight about what would be the course of thyroid nodule, let's say when it is detected in pregnancy, because that's the time when a woman gets attention at most. And second, last but not the least, would be, geriatric patients who would have one or the other, examinations being done, and thyroid nodule would be detected. So in a pregnant state or in a geriatric state, how would the approach have been different from what has been discussed? And what was your modus operandi during the peak of COVID?
Okay, thank you, Dr. Ajay. I'll just ask with start with the first question. I think our modus operandi was same as it would be in pre-COVID times. The only thing was we received less referrals. That is, less people were consulting for thyroid nodule. The reason is not known, but it is same. It commemorates with the findings elsewhere. That everywhere it's in the publications also. Everywhere there has been decrease in the referral for thyroid nodules, especially of elderly. Now this is not known why it is so. Whether it's fear of epidemic or earlier it was because of overdiagnosis. That's not known. But in pandemic with respect to thyroid nodule, it's important that whenever a USG of thyroid is done, or for that matter USG of neck is done, there has to be, that's Western guidelines, that we should have a RT-PCR done of COVID. And then if FNSC is done, it has to be done in PPE. Even the dentist, I mean, it's the same as for the dental people, that in the PPE only, this has to be done FNSC. Now this brings us to, a peculiar question, which is, I think it is for everybody, if not me, for everywhere. What should be the appropriate approach in our setting? How much we should ignore it, because the ESC guidelines on the COVID and the thyroid, they say they start with that thyroid nodule is not an emergency. So, but it's on the other hand, probably we are missing a lot of malignancies because of avoiding this, or because of less referral. Your second question of how should thyroid nodule be approached in pregnancy? It's actually in pregnancy, there are various reports, and the pathophysiology also suggests that thyroid nodule increases in chance, in size, as well as there's more detection of thyroid nodule. Now, these studies are very observational, so there's likely to be bias. The pregnant patients are more likely to be followed up and thyroid nodule picked up. That said, the chances of malignancy is more in pregnancy, there's no doubt. And how should we approach? The approach is like it is same as an adult patient, that we should be doing the USG, and we should be delineating the high risk characteristic which has been elaborated by the previous speakers. Yes, but it corroborates, whether it corroborates as well as good as in elderly is not known. Also in pregnancy, we should avoid I-131, but despite everybody knows this, it's fairly common for first trimester pregnant women to receive I-131 as a treatment for Graves' disease, which includes sometimes presence as nodule. So that is something which we need to consider, that I-131 has to be avoided. Last question on geriatric population. Geriatric population are more likely to have thyroid nodule. So and they're also more likely to have malignancy. But the percentage of malignancy in the thyroid nodule, that's less in geriatric population. Also, they are more likely to have neoplasm rather than papillary, which is more common in adults. Also, they're more likely to have what is called anaplastic carcinoma. That's very much common. I mean, that's much more common in elderly as compared to adult patients. So that is something one need to, that can be picked up early if thyroid nodule is given proper way. But the molecular the expression markers, they have not been validated in elderly patient. So the only way is to do a follow-up ultrasound and look for high risk and do FNAC in elderly. That's what it is there. Okay, thank you.
Thank you, Dr. Ravindra. Now I would like to invite Dr. Deependra Narayan Singh He is much sought after, the only endocrine surgeon in Rajasthan. Dr. Deependra, if you just come up. Since
Thank
you
you,
are
sir.
the surgeon among the endocrinology group, and perhaps most physicians would be viewing you. So how do you decide whether the patient would need a lobectomy or a total thyroidectomy, keeping in mind how do you advise the patients whether you do a one-step or you do a frozen and you do a completion thyroidectomy based on your experience, your valuable inputs on the matter?
Thank you, sir. First of all, I would like to thanks the organizers for inviting me in this prestigious dialogue. And regarding the optimal management, surgical management of thyroid nodule, uh, first we look into the clinical features, all the radiological investigations, sonographic imaging, nuclear scan if patient have, or PET scan, and the appropriately the pathological findings, cytology slides. We can review the cytology slide and appropriately looking the FNAC. Sometimes we just see the main report and don't go detail into the cytology, and sometimes we can miss these area. And now the newer modality just coming in the way, like molecular profiling, and just I am telling, I don't use till now the molecular profiling for the management of thyroid nodule till date, except in few germline mutation, which patient have red positive gene in blood, and in PGI we do prophylactic thyroidectomy for this medullary carcinoma thyroid. And it's actually a team approach where GP send patient to endocrinologist. Endocrinologist evaluate 1 centimeter thyroid nodule looked by GP, and on ultrasound he finds suspicious feature, sent to surgeon. And in surgery, lot of ENT people and onco surgeon and endocrine surgery people are involved in their management. And after surgery, we if malignancy, papillary carcinoma came out, we send patient to nuclear physician. It's just a comprehensive team approach for thyroid nodule, either it's 1 centimeter or 4 centimeter, or it's big thyroid nodule. And regarding the decision for how much thyroid surgery to be done, it's very clear, and it's based on we evaluate all these three features: clinical, radiological, and cytology finding. If it's clear cut benign and patient have single thyroid nodule which is having pressure symptom, more sometime if nodule is large, patient complain of cosmetic concern, then we may consider their base and go for hemithyroidectomy, provided the TSH is less than 3. Because we have seen if hemithyroidectomy done in patient who have TSH of 4 or 5, ultimately patient land up with a hypothyroidism, and we require thyroxine replacement later on in almost 30 to 40% patient. And in clear-cut malignant report or suspicious of malignancy, there's no doubt how much surgery we do in if size is more than 2 centimeter, and we straightforward go for total thyroidectomy, either in PTC, medullary carcinoma, or thyroid. And if size is less than 2 centimeter, there is no positive family history, and located in single lobe, The lobectomy itself is sufficient surgery in this scenario, and we can follow very well with ultrasound and thyroglobulin estimation. And regarding the how much lymph node dissection we do in papillary carcinoma, we always perform compartment-oriented lymph node dissection. If size is more than 4 centimeter, prophylactic central compartment lymph node dissection is required. And if patient have lateral compartment lymph node, then modified radical neck dissection is needed, either unilateral or bilateral.
Thank you, Dr. Deependra,
Thank you
for giving a surgeon's perspective on the thyroid nodule. We'll keep in touch with you. And last,
Thank you,
our
sir.
panelist, I would like to invite Dr. Abhinav Gupta. Dr. Abhinav, if you could just come up and introduce yourself.
Yes. Hello. Myself, Dr. Abhinav, working as a consultant endocrinologist at Rukmani Birla Hospital.
So, Abhinav, great to be on the panel. So, based on whatever discussions we had from the guest speakers and from the panelists, surgery perhaps even for class 3, class 4, and clearly for a malignant patient. But actually, patient's wishes should be respected. And supposing the patient refuses surgery, so my question to you would be, the good old teaching of a suppressive dose of thyroxine, how relevant is it today, first? And second, with the complete refusal of surgery of any sort by the patient, what are the alternatives that we can offer to these patients?
Yes. So far we discussed that incidence of thyroid nodules are increasing, almost 30 to 40% if we do ultrasound. I also have a question in my mind that majority of them are benign. Majority of these thyroid nodules are benign. Very minimal are suspicious for malignancy or require surgery. So all other patients, should we offer them surgery or should simply follow up? So here is the question. Some patients, most of them are benign. So now there is a chances of we can offer them to the minimally invasive thyroid intervention in these case patients. Which are these? Because majority of patients we can simply follow, but some patients have some cosmetic problems and they refuse the surgery. So we have some options like percutaneous ethanol injection is the one of the therapy where most of the fluid is drained. It is preferred for the cystic lesion particularly, and half of the 50% of the amount drainage fluid ethanol is injected. So I personally have no experience with this, but it is said that 80% size is reduced in these patients. And while for solid lesion, there are other therapies also like laser ablation or thermal radiofrequency ablations are done. Because many patients do not want to take risk of the surgery. There are a risk of permanent hypothyroidism, risk involved with during the operation, permanent scar. So why to give them that risk? So we can offer them. And as far as the thyroxine dose is concerned, thyroxine for the suppression of the thyroid gland, it is not recommended nowadays because of the side effect of the overdose of the thyroid in the euthyroid patients. And some earlier it was recommended, many people have used, but I have no personal experience with this.
Thank you, Dr. Abhinav. I think we are already past 10 and we should be thanking the panelists as well. And for this, I would like to invite Dr. Sanjay, the secretary of the READ concept and team. So Dr. Sanjay, if you could just deliver a vote of thanks for the so enriching and engrossing and active and a serious webinar that we've just witnessed, which is the first one of the READ. So Dr. Sanjay, if you could just come up on the screen and deliver a vote of thanks on behalf of me and the panelists to the invited guests and the delegates themselves who spared their time on their weekend for this complex and comprehensive topic on thyroid nodules.
Yeah, it's my privilege to have been asked to propose a vote of thanks on this academic event. On the behalf of Endocrine Society of India Rajasthan affiliate, I thank to all. Particularly, we are grateful to our eminent speakers, Dr. S.K. Singh sir, Professor and HOD of Department of Endocrinology, IMS BHU Varanasi, Dr. Rakesh Sahai sir, Professor and Head of the Department of Endocrinology, Osmania Medical College, Hyderabad, and Dr. KVS Harikumar, Consultant Endocrinologist with Magna and Vichy Hospital, Hyderabad, for sparing their valuable time on this for this mega event and enriching us from their bubbling knowledge on this mega event. I thank to Dr. Ajay Shah sir and all panelists for giving excellent coverage on this topic of thyroid nodule. I also thanks and express my gratitude for Dr. Keshwani sir, Dr. Shailesh sir, Dr. Ankur Gehlot, and all the organizing team for their untiring efforts to make this event successful. I also extend my thanks to all audience, which are in number, it are more than 400. Just I got the message from our technical team that more than 400 of audience have logged in. So I'm sure about this event that everyone must have enjoyed their knowledge sharing event. I always seek such kind of cooperation in our upcoming other events. Our next event will be on hyperparathyroidism. The topic will be primarily hyperparathyroidism. Our speakers are also like this event, they are master of their topic, master of it in the bone and mineral metabolism. First speaker would be Dr. Sanjay Bataka from PGI Chandigarh. Second would be Dr. Rajesh Khadgawat from AIIMS New Delhi. So I'm just requesting all the audience to come and enjoy the next of our mega event. So now we are closing our session with the thanks to everyone, and in the last thanks to our IT team, our technical arrangement team for the excellent work on this mega event. Thank you.
Thank you, Sanjay. With this, we come to the end of the webinar. Hope all of you enjoy your weekend. Good night and stay safe.
Good night. Good night, everybody.
Good night.